Okay, good morning, everybody. Welcome to today's webinar. Today's webinar is about the periodontal prosthesis. I am Professor Paul Tipton. I'm a specialist in prosthodontics, president of the British Academy of Restorative Dentistry, and also director of Tipton Training Limited back in the UK. So, what is the periodontal prosthesis? I think that's the first question that we need to ask and answer. So the periodontal prosthesis is bridge work. It is also known as the Linder and Nyman bridge. We'll talk a lot about Linder and Nyman in a few minutes' time. Jan Linder and Stu Nyman were periodontists in Gothenburg University. Stu Nyman has sadly passed away. Jan Linder is still around. He still lectures today on periodontal issues and on implant issues. And they were two periodontists that had the largest budget at the time, dental budget in the world at Gothenburg. And they were, their topic, if you like, for their research was perio, obviously, many topics. And one of them was looking at various ways of treating periodontal disease. The first way they looked at was whether you should do surgery, open flap, open scale and polish. And the second way was whether you should do a closed debridement, root planing, scale and polishing, etc., and looking at the results. And as they were going through the studies, they were collecting an awful lot of data. And the data they were collecting were from MSc students, from hygienists, etc. And many of that data was mobility scores, plaque indices, probing depths, etc. And some of the MSc students and hygienists were coming back to Linder and Nyman and saying that they're having difficulty scaling some of these very, very mobile teeth. So Linder and Nyman decided at that stage to do a separate study and to splint these teeth together to see if that would help the hygienists in gathering their information. So the next 50 patients that came in, they had their teeth splinted together, and they had their teeth splinted together with crown and bridge work. And like a lot of ideas or new discoveries, it was completely out of the blue what they found. They thought that they were just going to splint these teeth together. These teeth were terminal dentitions, and they thought that they were going to splint them together just so that they could get the results of the plaque indices, perio indices, etc. They followed these patients then for 8 years. And as you'll see in the results, at 8 years, they were amazed that 93% of all those patients, their bridge work was still not only in function, it looked as good as it did the first day it was put in 8 years earlier. Only 7% of failures. And these patients then have been looked at up to 20 years with, again, very, very good success rates. So this is what the periodontal prosthesis is. It is full arch bridge work placed on severely reduced periodontiums. The teeth that we're looking at, grade 1 to 2.5 mobile. Okay, so if anything was grade 3 mobile, as in apical mobility, then that tooth was either extracted or the patient was not used on the trial. And the restorations were mostly full crown restorations. Some of the restorations, the retainer types, were 3/4 crowns, but mostly full crowns. So of course, straight away, this flies in the face of what some people would suggest is bridge design. Now, a lot of our bridge design goes back many, many years. And as you can see here on the screen in front of you, Anti's law, which still many people use today as their way of designing bridges. Anti's law stated, as you can see, the root surface area of the abutment teeth should equal or surpass those of the teeth being replaced by pontics. Now, as you can appreciate, if we're going to put in 12-unit bridge based on 2 or 3 or 4 mobile teeth, then that flies in the face of Anti's law. That does not, is not the basis of Anti's law, is what I'm trying to say. And therefore, the question was, is Anti's law actually useful? And I think by today's bridge design standards, what we would suggest is that Anti's law is only now used in only one part of bridge design. And that one part of bridge design is for Canada came out with their studies. So this was their original study where they published the data in 1978. If you want to look and research the Linder and Nyman, there are multiple papers out there by Linder and Nyman and by their Scandinavian co-workers who've gone on and done more and more of this work. But this was the original paper. And as you can see, a longitudinal study of combined periodontal and prosthetic treatment of patients with advanced perio disease. And their conclusions were that long span bridge work, this is cross arch bridge work. It is not bridge work that's done in sections. It is cross arch stabilization. Long span bridge work with severely reduced periodontal support. Some of these teeth only had 3, 4, 5 millimeters of teeth remaining in bone. Has good survival rates if attention is paid to, and these are the important parts which you're going to discuss, retention, the occlusion, and the occlusal scheme is very, very important. Margin placement, and the success rates, as I mentioned, 93% over 8 years. This was the original paper. 93% over 8 years. And the failures were those 7% of the cases, those 50 cases. Okay, the failures were due to cementation failure of 3/4 crowns. And so Linder and Nyman came out in a subsequent paper and suggested do not use 3/4 crowns. They do not have a good enough resistance retention form for this type of bridge. Fracture of some of the component parts. So that's the frameworks that fractured. And again, Linder and Nyman came out and said, make sure that the frameworks are bigger size. Initially, some of the frameworks were quite thin to allow a lot of very easy self-cleansing. So some of the frameworks and connectors, therefore, were made thicker, bigger to reduce that failure rate. And the final one was that they got certain failures due to the end abutment tooth, the last abutment before the pontics, fracturing off at gum level. And they found that these were mostly due to having a root-filled tooth as the end abutment. And their conclusions again and recommendations were, if the end abutment is a root-filled tooth, then consider extracting it and having a greater number of pontics. Most of these cases were 12-unit bridges that were put in place with multiple pontics, sometimes 3, 4, 5 pontics. In one case, 7 pontics were cantilevered off the last abutment. So again, cross-arch stabilization, but off the last abutment, 7 pontics were cantilevered. And that was followed for up to 20 years. So when we're looking at the treatment planning of these cases, so let's look at our treatment planning for these patients now. We have patients in front of us all the time, our elderly patients who've got periodontal disease. Now, again, a big question is periodontal disease treatable? And the answer is, of course, yes, it is. Okay, we've got multiple studies that show if our patient is compliant, then most patients, we can control the periodontal disease. Yes, they may have the odd flare-up, but over a long period of time, it is controllable and it is treatable. So just because we have a patient with periodontal disease does not mean to say that those teeth will not last the patient 10, 20, 30 years. If they're motivated and they seek out good treatment and have good treatment, then these patients are suitable. So we have 3 alternatives. So we look at our patient with multiple missing teeth and with periodontal disease. Okay, number 1, of course, we treat the disease before we restore. So we're now looking at a patient with multiple missing teeth and treated periodontal, or been treated with periodontal treatment, okay, post-perio treatment. Our options are partial dentures, implants, or the bridge work, and we'll call the bridge work the periodontal prosthesis. Most of these patients are going to have free end saddles. And so the suitable patients for dentures would be the stable base denture. For those of you that don't know the stable base denture, then it's a concept from Michigan University, from Joe Clayton. It's the only mucosal bone denture which you can do for somebody which has got good occlusal form and it's good occlusal stability. So that means that you can construct somebody's occlusion using one of these dentures. I did a webinar on it not too long ago. For those of you that want to learn more about it, please go back and have a look at the webinar that I did. Otherwise, go and look at Joe Clayton 1980. The paper was published in Dental Clinics of North America in 1980. And basically what the stable base denture is, it's for patients who have, as we see here, free and saddles. Okay, again in the lower jaw, free and saddles. If you wanted to treat this patient with a periodontal prosthesis, then our patient would have a 12-unit bridge in place. And again, our patient would have a 12-unit bridge with multiple cantilevers. Okay, on that side there's not a cantilever, but it would be fixed, but cross-arch stabilization with multiple cantilevers in these areas. And I'll show you these cases as we go along. This is an option if you don't want to go down that route. Is it a safer option? Stable base denture will probably need changing at about 15 years. So the stable base is certainly a cheaper option. We don't need to put crowns on every single tooth. All we need is to have a crown with a fixed movable attachment. The crown has the female in on the tooth that is next or adjacent to the edentulous area. So you can see in this case, it's a minimum of 3 crowns and a denture, 2 crowns and a denture here. The fact that we've got some bridge work in the upper jaw, that doesn't really matter at this stage. So in terms of longevity, it's probably a similar sort of longevity. Cost-wise, it would be cheaper. And that would be the only style of denture which I would support as being mucosal borne for free and saddles. Now, of course, we've got implants as well. So what do we know about implants? Well, we do know that implants do fail. So we've got a huge amount of knowledge about implants now, but still we're having failures with implants. And that failure is to do with periimplantitis. If we rewind maybe 20 years to the year 2000, most of us involved with implants, and I've been involved with implants since 1986. So that is 20, 30, 34 years. And I've seen implants change. And I've seen the way that implants are manufactured change. And the original work by Brannemark, going back into the 80s, late 70s and 80s, would show us that we had a 90% success rate over about 15 years. And most people would suggest that that would probably equate to maybe a 75, 80% success rate over 30 years. Now, when we look at implants versus bridge work, conventional bridge work has a success rate very similar to implants, as long as you know how to design bridge work, which again is not a topic which is well taught at university, not well taught at the university. And if you're interested, again, I did several webinars on bridge design, which may be interesting to you. Now, if you look at any surgeon, oral surgeon, implant surgeon, periodontist, and ask them how long, if you're a patient, and ask the obvious question, how long is my implant going to last? Then most of the implant surgeons are going to say, we expect it to last 15 years, hopefully longer. And again, 15 years now puts it into the same bracket as the stable base denture and potentially the periodontal prosthesis. Now, the one thing we've got going for periodontal prosthesis over the implant is we're still using teeth. So again, we go back in time a little bit, and the year 2000, maybe up to the year 2010, before we really knew too much about periimplantitis. A lot of the treatment planning thought process criteria was, you've got teeth, the teeth are a little bit mobile, they're probably not going to last you that long. Let's take the teeth out now, let's preserve bone, let's put implants in and give you a reconstruction. That was great when we thought implants were going to last 30 years. But it's not so great if they're only going to last 15 years plus, because when the implant fails, very often the bone has gone with it, and our patient now needs bone grafting procedures. So one of the many features of the periodontal prosthesis is this word being conservative. We are doing bridge work on remaining teeth. If and when those remaining teeth do fail, we still have the option to go to implants at a later stage. So let's look now a little bit more closely at this periodontal prosthesis. First of all, let's look at success rates. Owl did a study in 1990 looking at 20-year backups of some of this type of bridge work. And he was specifically looking at 12-unit bridges on lower canines, okay? And again, this work, he followed 50 cases of 12-unit bridges done on 2 mobile canines, and the success rates at 20 years were over 50%. So 50% or more still had the bridge work functioning in their mouth. The other 50%, okay, they've lost the bridge, and now maybe they can go to implant work. Or in some patients, more elderly patients, the bridge has actually seen them through their final years. So success rates are excellent, okay? And our criteria for success is based on these principles, as you can see on the screen. First thing is that we can have a minimum of abutments with his mouth. If you look at all the periodontal studies, then the longest lasting teeth are your 2 lower canines, followed by 2 lower first premolars. So there's lots of bridges out there, again, using canines and premolars, followed by lower second premolars, followed by upper canines. Shortest lasting tooth, as you're probably aware of, is the upper first molar. So if we are going to do some bridge work on certain teeth, and we're hoping for longevity, it's good that we pick the teeth that have got the longest lasting lifespan in any case. Lower canines, lower premolars. So minimum number of abutments, maximum number of pontics. So you may be thinking, why did they always go to 12 units? What about 10 units? What about the shortened dental arch? Well, we can do 10 units, we can do 12 units. What has been shown over a period of years has been if we have no molar support or no premolar support whatsoever, so if we only have something canine to canine, then it's advantageous, especially in the upper jaw, to go and put pontics to the first molars. Let's try and work you through why. Okay, so let's think in the upper jaw. First of all, our lower teeth are hitting the upper teeth like that. In the lower jaw, forces are going down the long axis as we bite up and down, going down the long axis of the abutment teeth. But in the upper jaw, long axis here, we're biting at maybe a 60-degree angle. What's that doing? So let's imagine that we had canine to canine, or 2 canines left, that's all. And we did a canine to canine splint and put a partial denture in place. What would happen long term to the canine to canine fixed bridge? Okay, what will happen is we'll bite on it, and that bridge will eventually start to move forwards and forwards and forwards and forwards. Okay, almost like an orthodontic force. The occlusion will be like an orthodontic force moving it forwards. Now, let's change that bridge from being a 3-to-3 with a partial denture to a 3-to-3 now with 4, 5, and 6 as pontics, both sides. And those 4, 5, and 6 pontics have got shape to them, they've got inclines, and they've got good occlusal stability with the lower teeth. Okay, now what happens? We bite at the front again. Okay, as we bite at the front, the bridge will slowly just move slightly forwards. As it moves forwards, that means that the upper pontics have moved slightly forwards as well. What happens after the chewing cycle? We swallow. As we swallow, our teeth go into intercuspal position. Okay, now what will happen is that the lower tooth will hit on an incline. So at the back of the mouth, the bridge has been made, so the lower tooth hits into the central fossa. Okay, now the bridge has moved slightly forwards. Now when we close together and swallow, the lower tooth, hits into the fossa, and it pulls the bridge back into position. So we don't get this migration forwards. So those pontics are there for occlusal stability. Whether we have 4s and 5s, so we have 4, 5s, and 6s, they're there for occlusal stability. So it stops the forwards migration of the bridge. So maximum number of pontics. In one case, as I mentioned, 7 pontics cantilever distally off the last abutment. Acrylic and gold, or acrylic and metal work. So the Linder and Nyman bridge work was done with acrylic and gold. We've since done many with ceramic, okay, and we'll talk about which specific cases we do in ceramic, and other ones where we've done composite and metal. I'll show you cases there. Most of the time, super easier to keep clean, obviously. Will not affect the periodontal tissues, easier to maintain. Most of these bridges are not the best looking bridges. They're not there for big aesthetics. They are there for function. Our patients have to have excellent oral hygiene. All of our patients who go on to this type of bridge work initially have to go through periodontal therapy. Okay, they are periodontal patients in the first place. They go through periodontal therapy. That may mean pocket eradication. So these patients very often will have gingivectomies done to eradicate the pockets that way, rather than prolonged scaling and polishing to reduce pocket depths. And they have to show us that they have excellent oral hygiene. Of course, 1 or 2 slip back, and we'll talk about what we do with those patients. The whole scheme of things works because once the bridge is in place, it is mobile. Okay, and the whole concept of the periodontal prosthesis is a little bit like a living denture. Okay, so you can imagine you've got somebody with a full upper denture. You get hold of the full upper denture, and you can move it forwards and backwards on its denture base, on its soft tissues, by probably up to 1 millimeter, forwards and backwards, side to side. That's the denture, okay, and the elasticity of the soft tissue underneath. Now, the same thing with the Linder and Nyman bridge. Once the teeth have been splinted together, you can still get the bridge, and you can move the bridge forwards and backwards, side to side a little bit. What we found over the years, however, is that mobility stays exactly the same. So it works because of the increased mobility, and as we know from bridge design, mobility is our friend. As long as we have health, mobility in bridge design is our friend. Why? It's the shock absorber. It's the stress breaker that takes the stress off the cement lute, takes the stress off the abutment tooth, takes the stress off the ceramic or acrylic or composite on top. So we like stress breakers, okay? They will give us better longevity. So here, the periodontal ligament is acting as a stress breaker. And finally, we need to look at the occlusion. The occlusion is very, very important in this type of bridge. We don't go for our standard 5 principles of occlusion as we would do for any other case. This is a special case, special style of occlusion. And this is now a denture style of occlusion. So what you would normally do for dentures, which is bilateral balanced occlusion, is what we now put onto this type of bridge work. So it's balanced occlusion. And if you remember what balanced occlusion means, it means, okay, close your teeth together. Okay, with 99% of the cases that we do, the full mouth reconstructions, the cases for patients with wear who need restorations, we have our 5 principles of occlusion which we stick to. With the Linder and Nyman bridge, just like with full dentures, balanced occlusion. And by that we mean, as I slide my jaw to the left-hand side, I will have group function on the left-hand side. I will also have a non-working side sliding contact on this non-working side. So it's in balance. And what that does is it stabilizes the bridge. It makes sure that the bridge, again, does not start to migrate out. Just like it stabilizes the denture, it stabilizes the bridge. So let's look at our occlusion on the periodontal prosthesis. These are our 5 principles, which I'm sure you know. You've heard me talk about occlusion, I'm sure, many times. If not, then please go and look at some of my webinars on occlusion. So these are 5 principles, and these 5 principles we adhere to on every single reconstruction, except for full dentures, periodontal prosthesis. So 99.9% of probably the restorations that you're going to be doing, or the fixed restorations you're going to be doing. And what I'm going to go through now is, do we use these principles in the periodontal prosthesis or not? So our first one, RCP equals ICP around RAP. Yes, we're doing a reconstruction. So I want to make sure during my reconstruction that my condyles are in RAP. Okay, very important. RAP, hugely important position. Retreated axis position, correct position of condyle in fossa. That's a reproducible position. That's where our muscles are at their most relaxed. And it's also a bone braced position. And this is what we're looking at. And some people say it's the most superior position of the condyle in the fossa. Others will say it's the most superior, slightly anterior position of condyle in fossa. There's very little clinically between the two. And RAP, as we've mentioned, is a useful reference point because it's reproducible. I can get my patient there time and time again. I can show dentists how to get their patients there. So it's reproducible with me with time and age. It's also reproducible dentist to dentist, interoperator. And what is good about it, the muscles are at their most relaxed in that area. Okay, and also it's the condyle is being loaded in the ideal position. So just think, occlusion is all about mechanics. Occlusion is all about engineering principles. There's not much biology to do with occlusion. And what we're trying to do with occlusion day in, day out is give you a predictable end result by reducing forces in the mouth when our patient clenches and grinds. So these 5 principles do not occur in a natural ideal dentition. Okay, these are principles to form the best therapeutic dentition that you can do. So it reduces the forces on the masticatory system when people clench and grind. That's the basis. So our second one is a mutually protected occlusion. Are we going to be using a mutually protected occlusion? Well, the answer to this is no. Our mutually protected occlusion, as you are aware, is front teeth protect back teeth in forwards movements, sideways movements, back teeth protect front teeth in up and down vertical movements. Okay, and we call this anterior disclusion. The anteriors disclude the posteriors. In this instance, no, we want the anteriors and the posteriors to work together, just like you would do on a denture, to stabilize that denture. So we're going to have anteriors and posteriors working together. So do we have a mutually protected occlusion? The answer is no. What about anterior guidance? What's our definition of anterior guidance? Anterior guidance, the influence of teeth over mandibular movement. So yes, we need to have some anterior guidance. But we usually say anterior guidance, the influence of teeth over mandibular movement, preferably anterior teeth. So we're going to lose that preferably anterior teeth. So we're not going to have anterior guidance on the anterior teeth. We're going to have anterior guidance on anteriors and posteriors in an effort to try to stabilize. And we know from our standard occlusion that we want front teeth, and when we go into a forwards movement, to slide so that the lower anteriors slide on the upper anteriors and the posteriors come apart. What we're looking to do now with our new form of bridge work, our periodontal prosthesis, is to have the lower front teeth and some side teeth sliding at the same time so that we create this more stable bridge. Must not have this if we've got a patient who've got good bone support for our traditional dentistry. Otherwise, we'll get overloading of the masticatory system. No non-working side interferences. So we usually do not want any non-working side interferences. Non-working side interferences means class 2 leverage, means overload of teeth. overload potentially of muscles, potentially of joints. So we don't want that in our normal day-to-day occlusion. However, as we've mentioned, we want to have a non-working side interference, a balancing side contact in our periodontal prosthesis. So when it says no non-working side interferences, the answer, do we have it? No, we don't have no, we do have yes, non-working side interferences. And the non-working side interferences in traditional cases can lead to, as we mentioned, class 2 style of leverage, increased amounts of stress, and huge amounts of wear. Now, if you've got periodontal issues, this wear will not occur, it will create mobility. But if we're splinting everything together, in this case, because we've got mobility, the mobility acts as our stress breaker. And finally, posterior stability. Do we want posterior stability? The answer is yes. I want posterior stability so that my bridges do not slide forwards, do not migrate forwards. As we mentioned, that posterior stability, every single time we close together and swallow, like that, our teeth hit an intercuspal position, lower teeth hit on inclines, and that brings the bridge back into the correct position. So we chew at the front, the bridge migrates forwards, we then close and swallow, the bridge comes back. And hence we will always have that little bit of mobility in the bridge. So let's show you some cases now where we're going to deal with acrylic, ceramic and composite. And at the end, we will go through one long case study, which will show you the actual techniques. So first of all, acrylic. Here's our first patient. And this was the first patient that I did with the Lindner and Nyman bridge going back into the early 90s. Our patient, as you can see, has got periodontal disease, does not really want to have at this stage any implants placed. Can we work around this and buy him some time? Then yes, we can. So what we can see is he's got his last abutment tooth on the upper right is a first premolar. So he's got a free end saddle there. Last abutment lower right is a canine. Last abutment lower left is a second premolar. So we're going to have cantilever against cantilever, small cantilever against upper fixed. So this is our case when it's just been completed. Obviously, he went through periodontal treatment first of all to tidy him up, to make sure pockets are eliminated and to improve his oral hygiene. And this was a very, very nice, successful case. 12-unit bridge in upper, 12-unit bridge in the lower, functioned really, really well. However, at about 10 to 12 years, he started to get some caries. Not periodontal disease, but caries, which ended up us repairing the bridge work for 3 to 4 years. And at around about 15 years, the bridge was failing. There's too many carious lesions. And so we decided at that stage, we were going to go through another reconstruction, but this time use some implants. And you can see the diagnostic wax up here. And we now supported some remaining teeth with some implants. And that saw him through to the end of his days and worked very, very well. And now here's our porcelain fused to metal traditional bridge work. Okay, traditional splinted bridge work with implants supported around it. Now let's look at ceramic, and let's look at some ceramic cases. Here's first of all a case of ceramic with that 10-unit lower bridge. As we've mentioned most of the time, with the severe periodontal patients, we're going to see quite possibly a full upper denture and a lower situation where we've got maybe lower canines that are decent, the lower incisors, very mobile, deep pocketing and bone loss around the two premolars here. So we decided just to keep the two canines, and we've done a bridge with the two canines. We did this in ceramic, and you can see what happens. This is now 15, 18 years later. The ceramic is getting a little bit untidy. We've got further bone loss. Look at the further bone loss around the canines, and we've got bone loss around the lower incisors, but the patient has a fixed lower bridge And that fixed lower bridge has now been in place for 15 years, and quite possibly it's going to last another 5, 10 or 15 years. Against a full upper denture, again, bilateral balance, all of those concepts of occlusion that we've just introduced you to. Another case where we've got a patient who's overclosed, again, periodontal problems, missing an awful lot of teeth. We've gone in the lower jaw, and we're going to take out the 4 lower incisors, very, very mobile, and we're going to work with the 3s and 4s. Remember, the success rate of the Linder and Nyman bridge works on minimal number of abutments, multiple number of pontics. It could be that we could attempt to save these teeth, but it's not going to do the bridge work any good long term. Remember, from a bridge design generally, the more abutments you have in a bridge, then the more chance there is of failure, because failures tend to occur around abutments. Root canals happen around abutments. Cementation failure happens around abutments. Caries happens around abutments. So if I was to go now and do a 10-unit bridge in this gentleman and keep the lower incisors, it will just create more problems for the bridge. So we took those lower incisors out, and we're now doing a bridge on the canine and premolar both sides. And this is again just going to be a standard 10-unit bridge based on 2 premolars both sides. There's some mobility there, but this will hopefully last the patient 10, 15, 20, 30 years. Another one, very, very similar, not with the pink porcelain at the front. This is our pink porcelain at the front. Here's one again with 1 cantilever. Now, if you're going to use ceramic, then either use ceramic when you only have 1 cantilever, okay? 2 cantilevers, then that's going to be too much flexing and the ceramic is likely to fracture. So when we're doing cantilevers where there are more than 1, then we're more likely to go to acrylic or composite. We can also do ceramic when we're using patients who've got end abutments. We don't have to do the Linder and Nyman bridge with multiple pontics. It may be that there's an abutment both sides, maybe a 6 or a 7 both sides, and the cross arch bridge works very, very well. We just need to have molar support. And here's another case where we've got multiple abutments, all mobile, and we're going to be doing a Linder and Nyman bridge. And when the bridge is complete, it is going to be mobile. We're using a coat hanger wire and Duralay pickup technique. One of the reasons that we have to do this is, of course, if we take a normal impression, what's going to happen to those abutments? They're mobile. So if we've got abutments here, we take a normal impression, those abutments do that. So the viscosity of the impression material, even if we're using a very light body impression material, which I'd advocate, okay, we don't use putty and wash. It's light body and medium body is what we use as our impression material. And even though we place it very gently in the mouth, those teeth will move in their periodontal ligaments. And that will mean then that my master model will be inaccurate. So we use a 2-stage impression technique. I'll talk you through this on the final case that we're going to talk about. So this is Duralay and coat hanger wire technique, and we use that for mobile teeth. We now pick up the Duralay and coat hanger wire in a separate impression, and then we are making our definitive bridge work. Because it's a full arch, we don't make this in one go. This is going to be post-ceramic soldering. So we've got post-ceramic soldering going on in several areas here on our final bridge. Now let's look at composite. And I'm going to show you, this is going to be our last case now. And I'm going to talk you through this particular case with composite. So we have a lady here who has got 6 remaining upper teeth, 7 remaining lower teeth. She is very, very wary of implants. She's a little bit scared of having implants and the surgery done. And so she's been referred to me by her dentist for a stable base denture. He knows that I do stable base dentures, been on some of our courses, understands the techniques, and has referred the patient to me for the stable base denture. In talking to our patient, we also discuss Again, implants, no, don't discuss it with me. That were her words. Or the other alternative could be a bridge, a periodontal prosthesis style of bridge. We look a little bit more closely, and this is what she's got. And this is her once she's been cleaned up. We've got grade 2 mobility, grade 2 mobility, grade 2, grade 3, grade 1, grade 2. In the lower jaw, again, we've got grade 2.5 mobility, 2.5, grade 1, grade 2, grade 1.5, and grade 2. So we've got lots of mobility there. We've eliminated all the pocketing, and we've discussed with her a Linda and Nyman bridge. And we've discussed with her that we'll put a 12-unit bridge in the upper jaw, a 12-unit bridge in the lower jaw. Now in the upper jaw, as you can see, our last tooth on the upper left-hand side is a canine, so that's going to mean 3 pontics cantilevered off here. The first premolar is in place here, so that's going to be 2 pontics cantilevered off the upper right-hand side. And in the lower jaw, again, we've got a premolar, so 2 pontics here, we've got a premolar there, so 2 pontics in that area. So we're now going to have a 12-unit upper, 12-unit lower. Okay, our soft tissue is in good health. We've got mobility. So what are the stages that we're now going to go through? So our first stages are diagnostic, as they would be in every single case that we're going to do. And that diagnostics will be upper and lower impressions with alginate. Yes, the teeth will move a little bit, but I'm not that bothered at this stage. This is just for my study models. Once we've got our mounted study model, so it's upper and lower impressions, it's a face bow, it's a jaw registration around RAP. Remember, this is a full mouth reconstruction, so we're working around RAP. We now do our mounted study casts, and from our mounted study cast, we start to put our wax up to position, okay? So we take photographs, mounted study casts, and we start to do our wax up. Now, we're going to do a 12-unit bridge, but I'm only going to wax up 10 units. And I'm only going to put my prototypes or make my prototypes in 10 units. I'll show you why in a second. And we'll go through the normal wax up using the retromolar pads in the lower jaw as our reference point to the curve of Spey and our traditional curve of Wilson. We'll also look where the anterior reference point is with relationship to the upper lip and the patient's age, and the lower lip and the patient's age. So now we have our wax up duplicated into our definitive prototypes. And the prototypes I'd like you to look at just a little bit more closely. They are wire reinforced. Really important that when we've got pontics, so remember we've got 2 pontics here, we've got pontic there, we've got 2 pontics here, 2 pontics there, that those pontics during function, they're only acrylic with metal wire in place, they could fracture off. So the metal wire is there to give them some support to help fracturing off. And this is one of the reasons why we don't go and use a 12-unit temporary bridge or prototype bridge. You can imagine another pontic here and another pontic there. There is an increased risk that the acrylic will fracture. Is that a problem? Well, it is in terms of just the way that you discuss and maintain your patient, because you put a 12-unit bridge in place. The patient naturally thinks if one pontic fractures off, that that's an important pontic, and therefore comes back with that pontic in the fingers and say, can you please put this back? And you know yourself now, to try to put that back with a little bit of acrylic is going to fracture off again. So, and then for you to go and say to the patient, well, it doesn't really matter. You don't need to have that number of teeth. And the patient thinks that you're conning him, and he thinks that there's something wrong there. And you're losing a little bit of trust. So rather than do that, start off with 10-unit prototype and then go to a 12-unit definitive. So we do our tooth preparations in 2 stages. We do our impressions in 2 stages. So stage number 1 is we're going to prepare the teeth for our prototypes. So as you can see here, I'm prepping. I'm not prepping too much at the gingival margin, just a 0.5 millimeter chamfer. I'm preparing the teeth so they're fairly parallel to each other, not too difficult in the upper jaw because the teeth are fairly close together. Becomes a lot more difficult when we start to get space teeth and we then have to go to different styles of preparation. Sometimes you might need to go to this. This is called the parallelo prep, and it's a little device that allows us to cut preparations in all different areas of the mouth that are parallel to each other. This is made by Dentsply. I would advocate, if you're going to do some of these periodontal prostheses, and they are income generating, they are not cheap prostheses, then the first one, you should be charging enough money to go and purchase a parallelo prep from Dentsply, which will then allow you to prepare the teeth parallel to each other. If the teeth are not prepared parallel to each other, and when I say parallel, I mean the long axes are parallel to each other, but the preparations have got your standard 12 degrees convergence angle. So each tooth prep, 12 degrees convergence angle, but the long axis of the preparation, they're all parallel to each other to give you maximum resistance retention form. Okay, so this is the technique to use, especially if you have spaced abutments. If your abutments are all very close together, as in this instance here, it's not as difficult to be able to get the teeth parallel to each other. You can use eyes, and you can use the two-handed tooth preparation technique. Remember, when you're preparing these things, always prepare the two-handed tooth preparation. For those of you who want to revisit that, tooth preparation is essential in these cases. I did a webinar on two-handed tooth preparations and general essentials of tooth preparations. A lot of these preparations are done with the speed increasing handpiece, and with two hands it gives you an awful lot more stability, and it gives you a little bit more feel through your fingertips. So you can see, but you can also feel what you're prepping, and it gives you that little bit more ability to prep better. So our preparations are super gingival. At this stage, I don't want to go and put prototype margins underneath my soft tissue. Okay, my prototypes are never going to fit as well as my definitives. So why would I bother trying to get subgingival margins and only inflame what are periodontal difficult cases? We now take our prototypes and we reline the prototypes, upper and lower. So here's our upper being relined and trimmed, and then they're cemented in the mouth. So stage one, prepare uppers, prepare lowers, and put prototypes in. No impressions at this stage. Okay? Once the prototypes are in place, then we're looking at them for a period of time, probably anything from 2 weeks up to 3 months. And what we're looking at is the occlusion correct? With the prototypes, it's very easy to add some acrylic on, or some composite on, or take some off. So we're looking to make sure occlusally, do we have bilateral balance? That's the most important thing, number one. Number two, aesthetics. Are they okay aesthetically? Is the anterior occlusal plane correct? Is she showing the right amount of tooth? Is it the correct color? And you know that we may have to play around a little bit with the aesthetics. Number three, phonetics. Can she talk properly? That shouldn't be a problem, but in some cases it may be. So we now assess occlusion, phonetics, aesthetics, and general patient comfort. And when we're satisfied that we're happy with all three, the patients and yourself, then we're going to move on to our definitives. So our patient's happy at the moment with our prototypes. We're now moving on. So we take the prototypes off and we now start to do our preparations. Now our preparations can either be just left like this, super gingival, or we can take them to the soft tissue. Okay, now in the upper, where gingival margins are much more likely to be on display, more likely to take them to the gingival margin. So I'm now going to take my preparations a little bit further to the gingival margin, in some areas maybe even subgingival if you wish to. Now I know the original protocol was supragingival margins. Sometimes our patients do not like to see the metal margins. So in some instances we have to take that margin either to or subgingival. Otherwise our patient is not going to be happy with the aesthetic results. So in this case, we had to take them to or just slightly subgingival. So we've gone and changed our preparations. Our preparations now a little bit thinner because I've gone further up the tooth. but we've still got the parallel preparations. So here's my preparations in the upper, preparations now in the lower. And of course, with those preparations, we're now going to take our impressions. And of course, our first impression will be the teeth have moved slightly in their periodontal ligament. Okay, so we're not going to get what we'd call an accurate impression first time. Okay, so we're aiming for accuracy around the margins. Of course, I want great degree of accuracy around the margins. My technician needs to see those margins. But what we're talking about with the inaccuracy is the relationship between the teeth. That tooth will be slightly further forwards than that tooth, maybe. The teeth that are more mobile have moved slightly more. So in terms of trying to create bridge work that fits multiple teeth, if the teeth have moved, then the bridge work won't fit. So from here now, we go and take this impression and we silver plate it. Once we've silver plated the impression, then we will get the dies. We will trim the dies, okay, around the margins, and we will keep the dies only, and we throw the rest of the base away. I'm not interested. So from that first impression, we've silver plated it. The technician has now produced 6 dies for me. On top of the dies, he produces copings. These are Duralay copings, okay? Duralay, for those of you that may not know it, it's a red acrylic. It's a red acrylic which the technician uses. It's got, I won't say magic formula, but it works a lot more easily and it's more stable than using the normal traditional white acrylic. We've also got other materials we can use. GC have got a similar GC pattern resin. So whichever, GC pattern resin or Duralay, and our technician makes Duralay copings or bonnets. Now, important that these copings are made really well and they're made so they fit the margins superbly. So when we try these things in the mouth, we know that they are fitting. It's really important that these things fit down properly. So when I put them in place, I need to know if they fit or not. If my margins haven't been made very well here, okay, and the technician's been sloppy, when I try them in the mouth, there may be a gap. And if there's a gap, I'm now thinking the gap there, is that because the coping doesn't seat down properly? Or is that because there was just a gap between the coping and the silver die? So these things need to fit as well around the margins as a traditional crown would do. So we push fit these onto the tooth preparations. At the same time as making the Duralay copings, he's also taken some coat hanger wire, and that is coat hanger wire. It's the wire frames that you put a coat on and hang them up. Take the coat hanger wire and he bends the handle into the shape of the arch. And he sends the coat hanger wire, the handle, bent into the shape of the arch back to me. And he also sends me back a special tray. So he sends me Duralay copings. Very often he'll send me 2 sets because the second set I will use for the jaw registration. And again, we can get a very, very good jaw registration, passive jaw registration using Duralay. Again, think about it. If we've got teeth that are mobile and I now say to the patient, okay, close together, the lower teeth will hit the upper teeth and we'll move them. So we need to splint the teeth together when we do our jaw registration. So we do this for the impression and also for the jaw registration. So our technician has sent the coat hanger wire back. You now work with your nurse and the nurse holds the coat hanger wire onto the copings in the mouth. Just have a look at the copings, look at the shape of them. Okay, so the copings are made so there's a little indentation in the occlusal surface. So when we put these into the mouth, the coat hanger wire fits into that indentation. Now, all I do, the nurse holds the coat hanger wire onto the copings. I add a little bit of Duralay now from one side of the coping over the coat hanger wire to the other side. And we do that for each coping. That's called the bead-on technique, the Duralay bead-on technique. And it's a technique which is very, very useful for using in the mouth. dappens dish of powder, dappens dish of liquid. I talked through this in great detail when I did the stable base denture. So again, go and have a look at the stable base denture and you'll see in great detail the technique. So we use the coat hanger wire, Duralay copings and the bead-on technique over the top. Once the Duralay has set, what do we now have? We have these 6 abutment teeth all in their passive position, all now splintered together. All I'm going to do is, of course, now take an impression. As I take the impression picks up the Duralay copings and coat hanger wire, and then I go and take the silver dies, push them back into the copings because they fit very snugly, and then cast up my master model. And there's my master model. And we're going to do exactly the same thing now with the lower jaw. So I've taken the impression of the lowers. The teeth will have moved, but I've got good margins. The technician has now produced me 7 dies, produced me 7 Duralay copings. We go and put the Duralay copings, push fit them. You can see here in the lower jaw, I'm just supragingival. Wanted upper jaw, subgingival or equigingival, lower jaw, supragingival. Coat hanger wire on top, laying in the little hollows. Add the Duralay over the top using the Duralay bead-on technique. Take our impression, pick up that framework, put the dies, take the dies and put them exactly back in, push fit them into the copings, and then cast up our master model. So now we have upper and lower master models of the teeth in exactly the right position. The second set of Duralay, done exactly the same, and our jaw registration has been done. So this is our situation now. We're now going to go and do our occlusal registrations, and that is our face bow. We're going to put this onto a fully adjustable articulator, so we get a greater amount of occlusal accuracy. You don't have to do this, otherwise your technician will tend to overbuild and you can then grind it down and polish it in the mouth. Remember, what we're looking for are steep cusp angles palatally so that we can choose which one we're going to be using for our balanced occlusion. Remember, as we go close together, we slide to the left-hand side. I want to have group function on this side, plus a non-working side, balancing side contact on this side. That means that one of these palatal cusps needs to be steep. Same thing when I go to the right-hand side. Group function on the working palatal cusp on the non-working side, so that both of these things can slide together at the same time. So either go for accuracy or go for overbuilding and trimming down in the mouth the palatal cusp, your choice. So here we're doing a face bow. We're taking a reading of intercondylar distance so we can set up the fully adjustable. I'm going to be using a Cadillac machine. The Cadillac machine is going to give us not only the condylar inclination, immediate side shift, progressive side shift, but also going to look at the shape and form of the superior wall of the fossa and the distal wall of the fossa. All this can then be put into the fully adjustable. So I have my patient on the articulator and the articulator programmed to exactly the same values as our patient is. So this is the caveats in use, and we ask our patient to move to the right, to move to the left, to open, to close, to go forwards and backwards, and all the time a stylus is moving on this plate, this electronic plate, and feeding information through to a software program, which is going on to a laptop and giving the technician the values that are required. Our technician now sets this up on the fully adjustable articulator for accuracy. So I've now got my case on the fully adjustable, and all that my technician is now going to do is he's going to start to prepare the metal frameworks. So the first thing he's going to do, metal framework upper, metal framework in the lower, and we're going to try these in the mouth. We're trying these in the mouth to make sure that our margins are tight. No point in thinking too much about the occlusion yet. We've not got any occlusal material in place. However, once we've got the upper and the lower and we've verified that they are fitting correctly, that the margins are correct, if they're not, what would we do? We would section. We'd section and durolate together, and the technician would then solder together. So not all is lost if you feel that you've not got passive fit and you have a little bit of wobble. What we're looking for is to push up and down one side and the other, and make sure that we don't have one side pushing up, then the other side seating. We don't have a rock. Okay, we want a passive fit. So if we do have a rock, section. If you're going to section, do not section with a burr. Okay, the space that you create section with a burr is too great. It takes you too long. You'll use 5-6 burrs. Use a diamond disc, straight hand piece and a diamond disc. Ask your technician for a diamond disc, and be careful. That diamond disc, if you happen to be a little bit, what's the right word, inaccurate with it, can take a deep gash into your thumb. So we've got good fitting upper and lower. The next thing, always take that chance, that ability that you have then to verify the jaw registration. So I'm doing a bimanual manipulation. I'm just using now a simple little bit of bite registration paste between the two. So when the technician puts this back onto the articulator, he can verify that he's got the correct jaw registration. If these things don't meet well on the articulator, then he needs to remount to this new jaw registration. Now we're coming to the end, and at the end now we're going to put our composite in place. So our patient's going to have composite to make the teeth look like teeth. And as you can see in the lower jaw, we've got to the 6 with 12-unit bridge, same in the upper jaw, and then all that's left is to cement it in place. And here you can see we've got no metal margins on show in the upper. In the lower, however, we've got some metal margins on show, and we've got the 12-unit upper bridge, 3 cantilevers one side, 2 cantilevers the other side, lower bridge, 2 cantilevers and 2 cantilevers. So 12 units of upper and lower crown and bridge work. And the most important part now is, again, the occlusion. It needs to be aesthetic. It's not going to be the most aesthetic case you'll ever see. It needs to be aesthetic, but it also needs to have good occlusion. So let's look at this, a good occlusion. So now I'm asking my patient to move to the right-hand side. What do I want? We mentioned it already. I want group function on the right-hand side. So where do I want my group function? I want my group function around the abutment teeth. So you can see on the right-hand side, my abutment teeth are upper right. The 2, the 3, and the 4 will share the guidance evenly. That means I want to see red lines on the palatal aspect of the 2, the 3, and the 4 evenly shared. Now on the non-working side, my abutments are upper left 1, 2, and 3. I want to have my guidance. Now, if I can't have my guidance on that abutment, remember a balancing side contact needs to be on the palatal cusp. So we can't use a central, lateral, or canine because they don't have a palatal cusp. As my jaw slides to the right-hand side, it's got to be a palatal cusp that has the balancing side contact on. So I've now got to put that balancing side contact onto a pontic. And which pontic am I going to put it onto? The 4, the 5, or the 6? I'm going to put it onto the one closest to my abutment tooth, which is therefore going to be my upper left 4. So as I slide to the right, 3 sliding contacts there, 1 sliding contact here at the same time. Just like a denture, it is keeping the denture stable. It is not tipping the denture up. Exactly the same thing we're going to look at now on the left-hand side. When we go into left lateral, my abutments are 1, 2, and 3. So I want my guidance to be group function on 1, 2, and 3. Okay, so I want nice red lines on the palatal aspect of the 1, the 2, and the 3. Now when I go into that left lateral, what am I going to have on the right side? I want a balancing side contact on ideally my first premolar. My first premolar is an abutment. So here's my balancing side contact on the first premolar. So again, I go now into left lateral, Okay, I've got even contacts both sides, keeping the living denture, periodontal prosthesis, stable, as opposed to tipping it up. So here's the final end result. Here's my final smile. Nice looking smile. The quality of composite's never going to be the same as the quality of the porcelain. That's the last case, and that's the end of our webinar for today. I hope you found it useful. Our key points are that the periodontal prosthesis is a very, very useful tool, especially now when we're finding that implants aren't lasting as long as we'd hoped. All we need to do is to make sure that we get our patients so that they've got meticulous oral hygiene. We have established really good cleansing. We've got rid of the periodontal issues that the patient has. And this will now give us another option in our treatment planning for patients with periodontal disease or post-periodontal treatment, multiple missing teeth. We can have dentures, we can have implants, or we can have fixed bridge work. The fixed bridge work has to be for this situation where we're missing multiple teeth and we've got post-periodontal treatment. That bridge work has to be cross-arch stabilization. It has to be with multiple pontics or end teeth. We have to go for a 6 to 6 ideally. Sometimes we can get away with 5 to 5, but usually it's 6 to 6. We can choose our material. Longevity wise, we're looking at 20 years as being an average life expectancy, which puts it in similar sort of age range longevity wise to the canine to canine bridge. Average life expectancy 15 years. Implants, average life expectancy 15 years. So I hope you found this useful. We will now go to some questions to see if anybody has got any questions. I see that we've got one question already here. This is from Edgardo Benitez. Dr. Tipson, once your bridge work is in place, won't the weight of the prosthesis be an issue? No, it isn't. You'll be surprised just how much weight, how much stress that periodontal tissue can take. And so it's not. Obviously in the lower jaw, it's compressive. In the upper jaw, it will be pulling it down, but no, it doesn't seem to have been a problem in any of the case reports and any of the studies you'll look at. No. And also you'll look at this because most of it is acrylic and composite on metal frameworks. Those metal frameworks are quite light. Fatima, can this bridge be made in zirconia? Yes, of course it can. It can be made in zirconia, the same instances if we do porcelain fused to metal. So the answer is yes, it can. So the same criteria will apply. If you're going to use zirconia, then not multiple pontics. It's got to be a case where you're only putting one distal extension pontic in place, or you've got end abutments, but not multiple pontics. But yes, it will work in zirconia. Edgardo again, thank you for another interesting webinar. Okay, hi from the Philippines. Nice to hear from you again. Fatima, how do you exactly decide between partial denture and periodontal prosthesis? The decision is the patient's, Fatima. It is always the patient's. All you do is give the criteria there. So, longevity, the criteria similar. Aesthetics, criteria probably similar. How's it going to feel in the mouth? Do you really want something you take in and out, or do you want something that is fixed in the mouth? So it's probably going to be patient comfort that comes down to it. Possibly also cost. Periodontal prosthesis more costly than dentures, or especially a stable base denture. Fatima, what is 2.5 mobility? 2.5 mobile. So we have mobility, we have 1, 2, and 3 grade mobility. And of course, then you can also have halves. So split it down into halves so that you've got grade 1.5. What is grade 1.5? Okay, somewhere between grade 1 and grade 2. What's grade 2.5? Somewhere between grade 2 and grade 3. So all we're trying to do is give us a little bit more accuracy in our determination of mobility. Fatima, thank you. Hope you enjoyed it. Do you use gingival retraction cords? Francis, yes. So when I was doing the upper, you'll see gingival retraction cord in. I use either gingival retraction cord or gingival rotary curettage, like electrosurge, to trough around the soft tissue. One of those, it's usually, for me, it's usually at the front of the mouth, gingival retraction cord, and at the back of the mouth, I use the gingival troughing using a burr. Gingival rotary curettage. I find that easiest. Francis, do you take into account the type of opposing denture? Yes, we do. We've also got to look at the occlusion. Now, occlusion isn't just one. Occlusion is how the upper and lower meet together. So you've got to look at what's happening in the opposing jaw. And I suppose what you have to do is always look at which is the weakest component and try and protect the weakest component. So in the periodontal prosthesis, it's usually the weakest component is the periodontal prosthesis. So we give it bilateral balance with whatever is in the opposing jaw. Now, very few times are you going to have periodontal disease which has been extreme in one jaw and no periodontal disease in the other jaw. So it's usually going to be periodontal prosthesis against mobile upper teeth, periodontal prosthesis against periodontal prosthesis, periodontal prosthesis against denture, in which case it's bilateral balance every single time. Is it better to use ceramics rather than PFM to minimize the prep? Ovidiu, quite possibly. All I'm really saying here is that we've got longevity studies with PFM. We don't have any longevity studies with zirconia for this type of bridge work. We can extrapolate, and yes, I think now we could use zirconia as well, which would minimize the preparations, absolutely. And I think that's probably the next stage of development of this type of bridge. Fatima, when waxing up, is balanced occlusion worked out in the prototypes on the diagnostic mounting? Every single stage, Fatima. So you want your diagnostic wax up to have the bilateral balance in, the prototypes to have the bilateral balance, and then the definitives to have the bilateral balance. And again, we're getting the patient used to this from stage one. You're getting your technician used to it from stage one, and you're following it through all the way. So every single stage, bilateral balance. Mustafa, thanks for the webinar. The copings, if the copings do not fit 100% on the margin due to difficulty of the first impression, can we do a pickup with and redo? Yes, of course, you can always redo the impression again. That's not a problem. The whole point of the margins having to fit well on the definitive tooth preparations is you need to know if they're down or not. So if the coping isn't seated down, when the technician comes to reseat the die into the coping's in the wrong position. Therefore, the die will be in the wrong position on the master model. Therefore, your master model will be inaccurate. So if your coping does not fit the tooth well, but you can absolutely be 100% sure that it's down correctly in place, then we don't need it to fit that accurately. All the accuracy there is for me to make sure that it's down in place. And down in place, I program the margin and it fits intimately. Now I know it's in place. If it didn't fit intimately, I would have a question mark. Is it fitting properly or not? If it's not fitting properly, it may not be down, and therefore my master pickup impression may not be accurate. My master model may not be accurate. I hope that's answered that, Mustafa. Can vertical dimension be increased? Yes, absolutely, Fatima, no problem at all. You can choose your vertical. I'm sure you've watched my webinars on vertical dimension, facial aesthetics. Increased vertical dimension on this type of bridge, yes, no problem whatsoever. We've got the periodontal minimum, but we've still got periodontal support, which means I've got proprioception, which means I can now increase my vertical dimension and the patient be comfortable and adapt to it instantaneously like that. Francis, okay, thank you very much, Francis. Do I take account the opposing denture? Yes, I think I've done that. Okay, any more questions? 15 questions, guys. I'll just go through, make sure. Yep, I think every single one. Yep, okay, thank you very much, guys. Nice to see you. As ever, if you have any questions, then please email me. My email address is drpaultipton@gmail.com. Also be aware that the webinars are finishing. So I think we have our last webinar on Monday evening. That's the end of the month of finishing. We're getting back to doing our traditional courses. Our traditional courses are now going to be either full online PG certificates or a blended learning for the UK. So if you are abroad and you're unable to come to the UK, we will be doing online PG certificates, PG diplomas in restorative dentistry, totally online. We will send you all the material for the practicals, and you will video yourself doing the practicals so that we can mark you, so that we can give you a UK certificate and a UK diploma. So please watch out for that. That will be through BARD. So webinars coming to an end, traditional courses in the UK starting, and online certs and diplomas start the rest of the world. And if you want to, and you want any more information, please drop me an email, okay, www.tiptontraining.co.uk, or email to me, drpaultipton@gmail.com. Okay, take care. See you again sometime.